Hello, I'm Dr. Roger Henderson. I'm a GP and I also co-host the GPnotebook study groups. Welcome again to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, I'm going to be taking a quick look at basal cell carcinomas, a diagnosis so common in general practice that it can sometimes seem to fade into the background. It's the lesion we treat between more interesting cases, the cancer we reassure patients about quickly, and the pathology report we read with a sense of relief. But when we step back and examine its biology, clinical behaviour, and cumulative impact, basal cell carcinoma, or BCC in shorthand, emerges as a far more consequential disease than its reputation may suggest. So basal cell carcinoma is the most frequently diagnosed cancer in humans. Its incidence has climbed steadily over recent decades, a trend driven by ageing populations, lifestyle changes that favour recreational sun exposure, and increased detection. Now, in many regions, clinicians are also observing BCCs in younger patients, sometimes decades earlier than traditionally expected, and unfortunately in many cases with a link to sunbed use at a young age. And these trends raise important questions about prevention, early life ultraviolet exposure, and how we counsel our patients. Now, one reason BCC is underestimated is its remarkably low metastatic potential. And I'm sure, like me, for most of us as GPs, we intuitively equate cancer risk with the likelihood of spread and death. And because BCCs rarely metastasize, they're often framed as a non-dangerous malignancy. But this perspective actually overlooks the very real morbidity associated with their local invasion. Untreated or inadequately treated BCCs can erode cartilage, invade muscle, track along nerves, and destroy critical anatomical structures. On the face, these effects can be disfiguring, and around the eyes, nose, or ears, they can be functionally devastating. Clinically, BCCs present with extraordinary variability. And while the classic textbook pearly papule with telangiectasia presentation remains a useful mental image, many of these tumours actually look nothing like this. Superficial BCCs often appear first as persistent erythematous patches that wax and wane, leading patients and clinicians alike to attribute them to benign inflammatory conditions. More feiform BCCs may present as firm, scar-like plaques with indistinct borders, quietly infiltrating surrounding tissue. Pigmented variants may raise concern for melanoma, whilst others escape notice entirely until bleeding or ulceration forces attention. Now, patients frequently report that these lesions have been present for years, and this prolonged natural history reinforces the perception that BCC is harmless, even as the tumour continues to extend beyond what is clinically visible. The discrepancy between the surface appearance and subclinical spread is one of the defining challenges in BCC management, particularly for aggressive histologic subtypes. Now, ultraviolet radiation remains the dominant environmental risk factor here, but our understanding of its role has evolved, and it's no longer sufficient now to think only in terms of cumulative exposure. The timing, the intensity, and the pattern of the exposure all matter. So intermittent, high-intensity exposure, either natural or artificial in nature, and especially during childhood and adolescence, appears to carry a disproportionate risk. And this insight has implications not only for patient counselling, but also for public health messaging, as early life sun protection may have effects that extend decades into the future. And yet, ultraviolet exposure doesn't actually explain every case. A significant minority of BCCs arise on skin with minimal sun exposure, and this reminds us that additional carcinogenic pathways are at play here. Prior therapeutic radiation, arsenic exposure, chronic immunosuppression, and inherited DNA repair disorders all increase susceptibility. And in these populations, BCCs often behave more aggressively, recur more frequently, and present at younger ages. So recognizing these risk profiles is essential for tailoring surveillance and our management strategies. Now, at the molecular level, BCC is best understood as a disease of aberrant signalling rather than unchecked cell proliferation alone. The so-called hedgehog pathway, crucial during embryogenesis, is normally suppressed in adult tissues. Mutations that inactivate its inhibitory components or activate downstream signalling will lead to persistent cellular growth, and these alterations are present in the vast majority of sporadic BCCs. Additional mutations in tumour suppressor genes, particularly those involved in DNA damage response, reflect the cumulative effects of ultraviolet radiation and impaired genomic stability. And this molecular understanding has now transformed our treatment for advanced disease. For decades, surgery and radiation were the only viable options. But the development of hedgehog pathway inhibitors introduced the possibility of medical tumour control in cases previously deemed unresectable. Now, while these agents can be remarkably effective, their side effect profiles often limit long-term use, prompting ongoing research into combination strategies and alternative systemic therapies. Histopathology still remains a cornerstone of BCC risk assessment, though, and while all BCCs share common features, their growth patterns vary widely. Nodular tumours tend to be more contained and predictable, but in contrast, infiltrative and morphiform tumours extend along collagen bundles and neurovascular structures, often far beyond what the eye can see. Mixed histologic patterns are common, which complicates management when biopsy samples capture only a portion of the tumour architecture. And this variability underscores an important clinical reality. Biopsy confirms the diagnosis, but doesn't always reveal the full behaviour of the tumour. So as GPs, we have to integrate histologic findings with the clinical appearance, location, and patient history. A small lesion on the trunk, for example, in a healthy patient may be appropriately managed conservatively, whilst a similar appearing lesion on the nasal ala may warrant the most meticulous margin control. Now, NICE recommends that low-risk basal cell carcinomas be managed in primary care, as long as the GP meets the requirements to perform skin surgery within the framework of the direct enhanced services and local enhanced services. And there should be no diagnostic uncertainty that the lesion is a primary nodular low-risk BCC and that it meets NICE criteria. If it doesn't meet this criteria or there's any diagnostic doubt, following discussion with the patient, they should be referred to a member of the local hospital skin cancer multidisciplinary team. Surgical management still remains the foundation of BCC treatment. Mohs micrographic surgery offers unmatched margin assessment and tissue conservation, making it the preferred option for high-risk and recurrent tumours. And its value lies not only in cure rates, but also in preserving function and appearance. That said, Mohs is a resource-intensive procedure, and thoughtful patient selection is essential to balance benefit with accessibility. The overall cure rates with it for primary BCCs are almost 100% and 95% for recurrent BCCs. Other surgical and destructive modalities continue to play important roles. So standard excision, curettage, cryotherapy, and topical treatments can be highly effective in appropriately selected cases. The key is matching the modality to the biology of the tumour and the priorities of the patient. Cosmetic outcome, healing time, cost, and patient preference all influence these decisions, particularly in older adults or those with multiple lesions. Now, of the non-surgical treatments, imiquimod has the best evidence here to support its efficacy. Curettage and cautery is a good treatment for low-risk BCC, but is not recommended for recurrent, large, morphic tumours or tumours on the face, and the overall cure rate is over 90% for low-risk BCCs using this. Cryotherapy is well established for treating small, low-risk lesions, including superficial BCCs, and photodynamic therapy appears to be effective for the treatment of superficial basal cell carcinoma and nodular BCCs, with an average clearance rate for superficial BCCs of around 85%, but slightly lower with nodular BCCs. Radiation therapy occupies a unique space in BCC management, and it can be curative, organ-sparing, and effective when surgery is contraindicated. The best indications for the radiotherapy are BCCs with incomplete excision, recurrent BCC, nodular BCC of the head and neck under 2 centimetres, and BCC with invasion of bone or cartilage. However, its long-term effects on skin quality and the potential for secondary malignancies here do require careful consideration, particularly in younger patients. For patients with advanced disease, systemic therapy now represents both an opportunity and a challenge. Hedgehog inhibitors and, more recently, immune checkpoint inhibitors have now expanded our options for those patients who have few other alternatives. But these therapies require close monitoring, interdisciplinary coordination, and frank discussions about expectations and quality of life. But despite its prevalence, death from a BCC remains rare, and the prognosis is primarily about recurrence and not survival. Tumours in high-risk locations, aggressive histologic subtypes, and prior treatment failure all increase the likelihood of future disease. And perhaps most importantly, a history of BCC is a strong predictor of subsequent tumours, often necessitating lifelong surveillance, including an increased risk of developing squamous cell tumours and malignant melanomas. The cumulative burden of basal cell carcinoma is substantial. Repeated procedures, chronic anxiety, cosmetic concerns, and functional impairment can all affect a patient's quality of life. And from a health system perspective, BCC represents a significant and growing economic burden, consuming considerable clinical resources despite its low mortality. So in the end, I suppose basal cell carcinoma challenges us to rethink how we define seriousness in cancer. It reminds us that morbidity matters, that prevention is powerful, and that early recognition can spare patients years of consequences. The most common cancer in the world is not the most lethal, but it is one of the most instructive. So that's a quick overview of basal cell cancers, and I do hope you found it helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook if you have any questions, comments, or ideas for future podcasts. We really do enjoy hearing from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and also to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.